All right, so just to go back over blood clotting here, there were three main phases of blood clotting. First of all, we had vasospasm, which is the initial stopping of blood flow. This was pretty much initiated by the blood vessel itself, along with the sympathetic nervous system. So inherent properties of the vessel kind of stop that injury and prevent any flow of blood or any damage to the vessel initially. Then we see the sticky layer start to develop with the endothelium, right? That's when we get on to the initial platelet plug. So we start forming this initial platelet plug. We've got these clotting factors that begin to lay down, and that is created by a process called platelet adhesion. Okay, so we have that sticky nature at the endothelial site where the injury was, and then we start the second phase here, which is platelet adhesion. So platelet adhesion really comes from the exposed subendothelium. The subendothelium should never be exposed, and when we have an injury to that blood vessel, we expose that subendothelium such that von Willebrand factor, one of our factors that are in the blood always, so that it can point out or start adhering to exposed surfaces like this, starts adhering to that exposed subendothelium. So von Willebrand factor is going to start binding to the collagen fibers that are in that exposed subendothelium, and then it starts the second phase of what's happening here, which is the platelet aggregation. So after we start adhesion, which is the initial layer of von Willebrand factor on the collagen of that subendothelium, we then start to call additional platelet. This is platelet aggregation, and this is having a few hormones involved. So there's ADP, which increases the stickiness. There's serotonin and epinephrine, both causing vasoconstriction, so further preventing any additional blood loss. And then there is thromboxane A2. Thromboxane A2 being the really important factor in the positive feedback. So, okay, so that thromboxane A2 is really what's going to create that positive feedback loop that allows for additional platelets to start aggregating at the site. Okay, let's go down to this slide here. So here we have the platelets that initially adhered. On top of that, we have all these factors being secreted, ADP and thromboxane A2, which are making the region even more sticky and aggregating further platelets that are really binding on to that sticky layer that was created with the exposed collagen of the subendothelium, initially adhering to von Willebrand factor. All right. Now, really important to understand when this doesn't happen. So if there is no exposed subendothelium, healthy endothelial cells typically secrete nitric oxide and prostacyclin. Both of those things prevent platelet aggregation. So they prevent platelets from trying to stick to any of the surfaces of the endothelium. And so healthy endothelial cells will secrete this that will prevent what's happening here in this torn or injured blood vessel. All right. Now that's kind of the initial sort of temporary parts of blood, of hemostasis. The permanent part is going to be formation of the blood clot. This calls into effect the platelet factors that we talked about, those coagulation factors that are always circulating in the blood in their inactive form, made by the liver, and then they will be activated once we have some type of injury and we need to create this platelet clot. So the final stages of that are going from fibrinogen to fibrin, which is a loose, sort of temporary, unstable clot, and then we go to a completely stable fibrin clot with the help of our final factor here, which is factor 13A. So just to look at this clotting cascade again, which is another important part of hemostasis. So this is how we get our clot, our permanent blood clot that we create at the end. So this is basically the intrinsic and extrinsic pathway merging here. And the parts of this pathway that we mentioned were really important for you was the ending of the pathway here. So going from prothrombin to thrombin, or 12 to 12A, remember having that A at the end of the numeral here, the Roman numeral, is indicating that the clotting factor has been activated. And that happens with the help of these things here. So factor 10A, which was already activated previously. We've got factor 5, calcium, and then platelet factor 3. Then we go from thrombin. Thrombin has 3 main roles. So we talked at length about this. The 3 roles of thrombin are 1, activating fibrin, so fibrinogen to fibrin. 2, activating 13 to 13A. And in activating 13A is really important because 13A is what creates that stable fibrin clot, that stable meshwork, which is more secure than that initial fibrin loose meshwork. So that was the second role of thrombin. And the third role of thrombin is a positive feedback back onto the previous, or the clotting factors that are upstream in this cascade. Okay, so those are the 3 roles of thrombin, initiating more clotting factors coming down via this positive feedback pathway, activating fibrin, that initial loose meshwork, and then activating 13A, which will further secure that initial platelet plug. All right, so those are the really big picture aspects of blood clotting. And then we got into some other topics at the end here, which talked about dissolving that blood clot. So this is where we need plasmin. Plasmin is an enzyme, right? It's enzymatically active that is going to start degrading or attacking or breaking down that clot. In order to have plasmin, we need plasminogen activator. So plasminogen, again, is something that's always around in its inactive form. And in order to turn that into the enzymatically active plasmin, we need these plasminogen activators. Okay, an example of that, one of the most prominent ones, is tissue plasminogen activator, or TPA. So TPA activates plasminogen to plasmin, and that plasmin can start destroying those fibrin clots. Another important aspect what we talked about here was, Okay, so at the very end here, we spoke about aspirin and how aspirin could have a dose-dependent anticoagulant or coagulatory effect. So at low doses, aspirin is going to inhibit thromboxane A2. And if you remember, thromboxane A2 was one of our initial platelet aggregators. It's going to start aggregating platelets. And so low doses of aspirin prevents that initial platelet aggregation. And so it has an anticoagulatory effect. On the other end of the spectrum, high doses of aspirin is going to inhibit prostacyclin. And we also just talked about how prostacyclin is something that is secreted from healthy endothelial cells. And so that would prevent any platelet aggregation. So if we have inhibition of prostacyclin, we're going to have a lot of platelet aggregation, right? This is something that shouldn't naturally happen. And so that is going to be a pro-coagulatory or coagulatory effect, okay? So different effects depending on the dose. Low dose, it's going to stop coagulation. High dose, it's going to promote or initiate coagulation, all right? Any other specific questions? I think that was the crux, kind of a good summary of the important aspects of blood clotting. Any other fact or any other questions on anything here? So the 3 steps involved, we've got the initial vasospasm, platelet adherence, so platelet adhesion, those are kind of the first steps, then platelet aggregation, then that fibrin clot formation. Okay, let's see. Another question at the end here, so is the exam cumulative or just this semester's content? Okay, so that's a really good question. It's not going to have last semester's content. But there are certain things that you're expected to still know from last semester, right? Such as the flow through the vasculature. So just building on some of those concepts, although none of the questions will be directly from those exam units, right? And yes, it is completely cumulative, but just for this semester. Okay, so let's go ahead and get into our questions here. And again, if you have topics that come up as we're going through these questions, feel free to just pop them in the chat and I can just veer off temporarily and discuss those topics. Okay. Oops, can't access this. All right. All right, so we'll do this just the way we typically do. I'll probably give 40 seconds, just so we don't spend too much time just waiting for responses. And we'll just start right from the very beginning. So questions from exam 1, and we will keep going from there. So I'll do 40 seconds, and then we'll discuss. All right, so let's take a look here. So lots of response for C. C is correct. Which of the following would increase the rate of blood flow through a blood vessel? C is correct, which is the increased pressure of the blood entering the vessel. And so if we think about our flow rate equation, remember flow is going to be directly proportional to our pressure gradient, and inversely proportional to all the other options here. Viscosity, that is the thickness of the contents, which is blood. Constriction of the vessel, which is synonymous with the radius. So as the radius gets smaller, flow also gets smaller, and then increased length. So as the length gets increased, the flow also decreases. So there's a indirectly proportional relationship between, or inversely proportional between the other variables and flow. All right, so the answer here was C. Okay. Right, final few seconds. All right, let's see. Okay, lot of response for A. Which of the following would decrease the rate of blood flow through a blood vessel? So A is correct. Again, looking back at what we just said for that previous question, viscosity of blood is inversely proportional to flow. As viscosity goes up, flow goes down. Everything else is going to increase flow. So vasodilation, making our lumen larger, that'll increase flow. Increased pressure, that's going to increase our pressure gradient, that's going to increase flow. Decreased length of the vessel. So because length is inversely proportional, if we decrease the length, we're also going to increase the flow. And then increase radius of the vessel, same thing. As we make the radius wider, we're going to increase flow. So the only one that would decrease flow is A, right? Increasing that viscosity. All right, let's see here. Okay, a lot of response for A. So which is not an extrinsic factor that increases mean arterial pressure? So a lot of you selected A. A is an extrinsic factor. It is also going to increase mean arterial pressure. So both of those conditions are satisfied with A. So A is not correct. Let's see the other responses. The other responses will kind of split here. So the answer is actually B. And let's talk about why it's B. So essentially, first of all, this is not going to increase mean arterial pressure. Remember, epinephrine at beta-adrenergic receptors causes vasodilation. And so that vasodilation is going to actually decrease mean arterial pressure, right? It's going to open up the vessel and it's going to decrease mean arterial pressure. The second reason it's wrong is because it is not an extrinsic factor. It's not a hormone or the nervous system per se. It's going to be a local effect at the arterioles. And so it's causing vasodilation, it's happening locally. And so those are the reasons that it's going to be B instead of the other three options. Okay. All right, so the answer here was B. So be sure to go over your arterials, since quite a few of you got that one wrong. Go over your intrinsic versus extrinsic, your active hyperemia, reactive, all those mechanisms, that dose-dependent relationship with epinephrine as well. All right, let's take a look here. A lot of response for C, which would not allow many proteins and large molecules to permeate other cells. So C is absolutely correct. The continuous capillaries, very small pores or openings in between the endothelial cells here. And so there's not much of large molecules or proteins that can get through. Okay, that's not the case with the other types of capillaries, fenestrated, discontinuous sinusoids. They all have larger openings or pores. Okay, got another. All right, last few seconds. I'll give a few other seconds here. Okay, let's see. All right, so there's a lot of response here for D. So the question asks, which process occurs locally when a small group of cells are using oxygen and producing carbon dioxide faster than these gases can normally be replaced and removed at the capillaries? So a lot of you selected D, anaerobic metabolism occurs due to lack of oxygen. So that's not correct, okay? Let's go through the list here. Arterioles dilate, delivering more blood. So that would make sense, right? If we're using up more oxygen and producing more CO2, that is an indicator, that's a trigger to have arterial dilation, to have opening of the vessels so that we can deliver even more oxygen and remove even more of that CO2. Let's see B, heart rate increases, delivering more blood. So that doesn't necessarily happen. That is not going to be a local response to the tissues consuming more oxygen or CO2. The heart rate is not going to change to deliver more oxygen. What's going to happen is the vessel is going to be manipulated in order to bring more or less blood there. Autonomic system causes vasodilation, delivering more blood. Again, no, this is a local response that is going to allow more delivery of oxygen because of the local factors. Remember, these local factors, things like oxygen level CO2 level, even the lactic acid buildup from the muscles. Those local metabolites stimulate the vessel itself. That's all happening locally. So the heart is not involved, the autonomic nervous system is not involved, and then D doesn't happen, right? The cells don't just do without oxygen. They actually open up the vessel, dilate that arterial, bringing more oxygen in and able to clear more of that CO2 away. All right. Anyone remember the name for this process? You could drop it in the chat. So there's a name for this intrinsic mechanism where when we have more metabolites, we've got changes to the vessel to clear those metabolites. If we have less, we also have changes to the vessel to clear less. Remember the name of this mechanism, that'd be nice. Okay, in the meantime, let me move on here. Okay, so that would have been active hyperemia, by the way, okay? That's active hyperemia, which is different from reactive hyperemia, which is where we have some type of blockage or so. Okay, moving on. All right, last 5 seconds. Okay, quite a bit of polling, so let's just, okay. So we can probably do 50 seconds. All right, lots of response here for D, which is not a force that directly drives fluid into, which is absorption, and out of filtration, the capillaries. So essentially, what are the Starling forces? It's another way to rephrase this question. So a lot of response for D. D is the ionic driving force caused by ions in the blood. So that is not at all involved with the Starling forces. There is no involvement with ions or any type of ionic force. A, the pressure of the fluid inside and outside the capillaries. That is definitely one of our Starling forces. That's the hydrostatic pressure on either side. The osmotic pressure caused by cells that cannot pass out of the capillaries. Same thing, that's our osmotic or oncotic force. And then C is just the same thing as well. It cannot pass into the capillaries. So these are all forces excepting D, which has nothing to do with our Starling forces. Okay. So the answer here is D. Let's move on. Okay, let's do a couple more seconds here. All right, let's see. Okay, lots of response for D. When a person is cut, the tissue in the area swells in part due to increases in histamine and damage to the capillaries that allows more protein to filter into the interstitium. Which Starling force is increased owing to this protein movement? So D is correct, right? The interstitial fluid osmotic pressure is now inappropriately increased. There shouldn't be proteins or impermeant solutes in the interstitial fluid region. And so when we have that injury, which secretes histamine, along with the capillaries. Remember, histamine makes the capillaries leaky. It makes proteins kind of just go right through the endothelial layers, the endothelial pores, along with the physical injury to the endothelium. So proteins escape out, increases our interstitial fluid osmotic pressure, which pulls more fluid out into the interstitium and creates that swelling. All right. Okay, let's look at another. Here I'm going to give you, let's do 1 minute and 10, just so you have some time to work this out. I'll just recall the formula. All right, so let's see, that's our response here for D. So given our values here, so hydrostatic, capillary hydrostatic pressure 30, interstitial fluid hydrostatic pressure 5, capillary oncotic pressure 25, and then interstitial fluid oncotic pressure 10 millimeters of mercury. Okay, so based upon what we know, we first find out, first of all, D is correct. So most of you selected D, which is 10 millimeters of mercury, favoring filtration. And so we know we find our filtration versus force. We find our filtration forces first. The forces that are favoring the movement of fluid from the capillary out into the interstitium. So that's going to be 30, which is our capillary hydrostatic pressure, so standing in the capillary, pushing out, as well as 10, our interstitial fluid oncotic pressure, standing in the interstitial space and pulling towards. So both of those forces are favoring filtration. So that's going to be 40. And then we look for our absorption forces, so our forces that oppose filtration. So that's going to be 25, which is our capillary oncotic pressure, and 5, which is our interstitial fluid hydrostatic pressure. And so it's going to be 40 minus 30, which is 10, right? And the net direction is filtration. Okay. So the answer here was 10. So please brush up on this, right? Figuring out the values, which is favoring filtration, absorption, and then that final calculation. Okay. Okay. All right, let's see. So a lot of response for D, by moving skeletal muscles and by alternating pressure in the abdominal and thoracic cavity by breathing. So that is the skeletal pump and the respiratory pump. You pump blood in the veins through their valves back towards the heart, which is not a result of increased activity of these pumps. So they're identifying the skeletal muscle pump, which happens with the distal skeletal muscles, and the respiratory pump, which happens with the alternating shape of the diaphragm with respiration. So they're asking which of this listed below is not a result of those two pumps. So increased venous pressure is a result of both of those pumps. We're increasing the pressure in the venous system to push more blood back into the heart. Increased mean arterial pressure is an end result, right? If we increase the filling of the heart, we will then increase the ejection and by extension, increase mean arterial pressure. Increased end diastolic pressure is also a response, right? As we increase the force with which blood is coming back to the heart, that is how we can increase venous pressure and then mean arterial pressure. So A, B, and C are correct. Venomotor tone is a mechanism all of its own. This is where we involve the sympathetic nervous system, and this is where the veins have a small amount of constriction if there is, small amount of constriction that allows for more blood to be going back towards the heart. So when there is increased stretch on the walls of the vein, that allows, via the sympathetic nervous system, for a slight constriction, which is that venomotor tone, which slightly decreases compliance. Remember, compliance is the givability, the obedience of the vessel, and having that small amount of venomotor tone decreases our compliance slightly and also aids with our return to the heart. But it is not involving the skeletal muscle or respiratory pumps. It's a different mechanism with the sympathetic nervous system. Okay. All right. So the answer here was D, an increased venomotor tone. All right. Let's do 10 more seconds here. All right, let's see. So lots of response for A. What are the three factors that completely determine mean arterial pressure? So A is correct. It's our heart rate, stroke volume, that together is cardiac output, and total peripheral resistance, right? So it could have also been just cardiac output and total peripheral resistance. But if we further if we further break down cardiac output, we get heart rate and stroke volume. So A is correct, okay? Let's just look at the others. So the others, atrial pressure is out. Okay. All right, let's look at another here. I should have probably mixed these questions up so we can get a bit of various topics, but because we're drawing near with time, I may probably just skip over to exam 2 or 3 so we can see some additional topics. All right, let's do 5 more seconds. All right. Okay, a lot of response for B. How do arterial baroreceptors help change the mean arterial pressure? So this is one of those homeostasis loops, right? So it's going to be sending signals to the central nervous system, specifically the medulla oblongata, and then that center will send out efferent signals that result in hormone release and then neurotransmitter, which are autonomic signals. So B is correct here. And let's see, A, let's kind of go over why the others are wrong. So we're not sending signals directly to the SA node from the baroreceptors. That's not true. We're not sending signals directly to the vessels. That's also not true. And we're definitely not sending signals directly to the ventricle. So we must go through the integrating centers before that efferent signal can be sent. So this is a homeostasis loop. And so B is the best answer here. Yeah, so someone's asking about, will these questions be available? Yes, I'm going to share this PowerPoint so you can go over these. The questions are broken down by exam. So exam 1, 2, 3, 4. And you can definitely use these and go over and study after. All right, last 5 seconds. Let's see here. So lots of response for B. When a person stands, mean arterial blood pressure can fall and the baroreceptor reflex is activated, which is a change associated with this reflex. So when someone stands really quickly, their mean arterial pressure falls because of vasodilation, right? Vasodilation within the arterioles, which many of you correctly selected, is what's happening here to initiate that baroreceptor reflex that would send a signal to the brain. The brain would respond by allowing for vasoconstriction, which would increase mean arterial pressure. So decreased compliance of the veins is not happening. Decreased stroke volume is not happening yet. Increased parasympathetic activity is also not happening, right? It's a vasodilation that's appreciated from the baroreceptors. They're going to read it as low pressure and then send those corresponding signals to the brain to result in changes to prevent you from fainting, okay? Oh wait, hang on here. I may have misread this question, give me a second. Okay, I think I misread this question here. So it's asking about the baroreceptor reflex and the response that is activated. So not necessarily what's happening when someone stands. So the response activated from the baroreceptor reflex is going to be that venomotor tone that we spoke about. So the sympathetic nervous system will respond by stimulating the veins. They're going to elicit that venomotor tone, which is going to cause a slight bit of constriction on the veins to increase venous return, and that we said is also going to slightly decrease compliance, okay? So it's asking more about the response after the baroreceptor reflex and not necessarily what's happening on to initiate or elicit that reflex, all right? So here's decreased compliance, in other words, venomotor tone. I'm seeing another question here, just a bit of a tangent about the final. Yes, this will be the same Zoom link for class for the final. So there will not be an additional link, so you can meet right here at this link for the final. Okay, we've got a few minutes left. I want to just skip quickly to maybe some other topics. Just so we can get some other topics going. Let's do exam 2. We'll do another 2-3 seconds here. Okay. So which of the following is not a part of the conducting zone? That's going to be D. Many of you selected D, the respiratory bronchioles. Remember, the main difference here is whether or not gas exchange is taking place. The conducting zone, there's absolutely no gas exchange yet. In the respiratory zone, which starts with the respiratory bronchioles, we do have gas exchange. Okay. All right, let's look at another here. Actually, let's skip down to a few others. We probably only have time for one more, so let's. All right, last 5 seconds. Lots of response for D. So in normal breathing, which muscles contract for inspiration and expiration? So this is something that we really harped on, and D is correct. The inspiration is controlled with the external intercostals and diaphragm. Expiration is none. Okay, expiration is passive, and so no muscles contract for expiration. The expiratory muscles, however, so be really careful about reading the questions. If I talked about forced breathing, the expiratory muscles would have been C, and some of you did select C. So the expiratory muscles would have been the internal intercostals, but that is not required for normal